so that they encourage you to fill it in after the seminar and put it back in this box on your way out. If you haven't signed up on the webcast permission form, Charlene will be around to make sure that you do so that you have our permission to be part of this webcast event. I just want to shut this back door. And sometimes people come in late, but we're going to start. And I am so pleased that Dr. Joel Sadavoy is here today to talk to us about the Wellness Center and detecting mental health in ethnic minorities and the barriers that they pushed through at the Wellness Center to be able to do so, to give them the services that they need. And I don't know if you know much about Dr. Sadavoy, but he's the founding member of the American Geriatric, the Canadian Academy of Geriatric Psychiatry, as well as the founding member of the Geriatric Division at Baycrest, and the head of that department, and a founding member of the Geriatric Psychiatry Division here at U of T as well, and the head of that department, or division, as it were. Has done all these major things. And he's been a past speaker here at the seminar series with a project that's similar, and he tells me that the roots of that are going to be visible in this presentation. The Wellness Center, I take it, is the culmination of part of the project work that you did back then.
Yeah, it's the application of the research.
Yes. So we're so pleased he could be here today. We're sorry the rain is keeping some people away, but they'll be able to be watching via the webcast. And thank you very much, Dr. Sadavoy, for coming.
I'm delighted, thanks. So we have a small group here, but we know that there are scores of people in somewhere in the Ethernet watching us, right? So we can be a little bit informal here. We're a small group, and just feel free to break in, ask questions, or whatever. I'm happy to be diverted. The last time I was here presenting formally, I talked about a research project that looked at barriers to access to care for ethno-racial communities. And that research, along with the research that others have done in Canada and elsewhere, has set out a number of principles that, were they to be operationalized, theoretically, should produce a better service and portal of access for people who are ordinarily underserved in the community for a variety of reasons. Seniors are often underserved for all kinds of reasons. Ethnocultural communities are often underserved, and those with mental health disturbances of various sorts are underserved. When you get the intersection of all three, you get a very vulnerable population that is likely going to have difficulty in one way or another getting to appropriate care or seeing themselves as being either in need or understanding how to get to care. So we took the evidence from our work and others, and we began to think about how we could creatively develop a program that would address the key factors. And so that's why we are calling this an evidence-based approach to building mental health services for ethnic elders in Canada. We call it mainstream because this program sits inside the umbrella of a mainstream hospital. But it is an atypical kind of service for a hospital of that sort, and it has the advantages and challenges of being creative. So I'll tell you about it, and we can go on. I'd like to look a little bit at why it's necessary to even think about something like this. Why is it relevant to the healthcare system? What are the principles that we've used, tried to operationalize in running an acceptable, competent program? And what are the challenges in delivering this kind of program? So first, the inevitable background data. If you come to this series of seminars, I assume you're going to see versions of these slides 100 times, if you haven't already. But all it does is really look at what we all know. That is, 30 years ago, the numbers of elders, the red numbers, total numbers of elders were relatively small compared to now. They're about 4 million. And then currently we're at about 14% of our total population are elderly. That's the blue line. The blue line is the percentages of elders, and the red are the absolute numbers. So we're up close to 5 million elders over the age of 65 and older. And in about 16 years from now, the projections are that we're going to be at a percentage of something in the order of between 20 and 25% of the population. So certainly dealing with geriatrics is a growth industry in many ways. It's certainly a growth industry in healthcare, but policies and processes lag way behind, I think, the actual needs, and it's up to us, I think, to be able to think these things through and see what needs to be done. The growth in the Canadian population is interesting, because if it was just natural birth rates that we were looking at, growth probably would not only not occur, but the population would decline. The growth rate in the Canadian population is, as you probably know, due to immigration. And I put this slide up just to show the difference. If we're going to be looking at issues of immigration and ethnocultural populations, why is it so relevant? Well, in the last 50 years, there's been a dramatic shift. So you can see that Asia, the yellow, Asia and the Middle East are now the predominant places where immigration comes from, whereas when we started to think about these things, it was largely European immigration. So that's a major shift for us in many ways conceptually in this country. This is a breakdown. Our data is not great in these areas. We're always lagging behind because of census data and so on, and now with these new census rules coming along, I don't know what we're going to get, frankly, in terms of being able to really understand what are the communities that we have, what might they be struggling with, and so on. So our total visible minority population in purple is about almost a decade ago, and it was around 13% of the Canadian population. This is not geriatrics in general. And now it's gone up to about 16% of the population, or probably more than that, actually. Of these, well, I'll just say this. So it grew 27% visible minority population between 2001 2006, and I don't have the latest data around that, but obviously it has gone up that much more because it hasn't stopped. In the next 6 or 7 years, the projection is that about 20% of Canadians will be part of a visible minority, and of that group, about 25% will be foreign-born, they'll be immigrants. So we're not just dealing with visible minorities, we are also dealing with immigration. And they are not the same thing, although the problems tend to overlap, and we can talk a bit about that. Half will be Chinese or South Asian. Now, in Canada, mercifully, we don't make the same categorical mistakes that the U.S. has made for a long time, and I think is coming to realize as a problem, and that is we don't lump people quite as grossly as the Americans have. So when they talked about South Asians, for example, they talked about Polynesian Islanders in the same breath as Japanese. So culturally, I think we've got a more fine-grained approach to that. Whether it's relevant or not, I don't know, but it seems to me it's relevant. We have to recognize the differences and address them. So, what's the relevance to Toronto? We know this story, it's in the newspapers all the time. Toronto is highly diverse. We're now approaching 50% of our population as a visible minority, and Vancouver is similarly distributed. So it is the urban centers that are particularly interested in this issue of the delivery of service to highly diverse populations. Now this is interesting only because, I don't know if you can see it, but these are ethnic minorities listed, right? What's at the top? English, then Chinese, then Canadian, then Scottish, then Irish. I don't actually know what how this is all sorted out. Ethnic minorities. Does English mean people who were born in England, whose grandparents were born in England, who speak English? I don't know exactly. Similarly, I thought maybe it was language, but then I see Irish. So I don't know exactly what these categories are, but this is census data, so somebody came up with this. In the meantime, the largest group in Toronto and in Canada, that is kind of a relatively homogeneous group, that is a single or a relatively single language group, for example, are the Chinese. The South Asians are made up of a number of different groups. The Chinese tend to be more homogeneous. Why is that relevant? Because it's the group that we're going to talk about here, because that's what this program is oriented to. So if we can turn our lens now to the Chinese elders of Canada and North America, I'm presenting this data because it's there. I have a little trouble with it because it tends to be to indicate that the rates of mental health disturbance, depression, and so on are higher in ethnic groups in Chinese than they are in other groups. I worry a little bit about it because anytime researchers start to focus in on a population, the tendency is to try to get dramatic results. So take it all with a grain of salt. However, Daniel Lay said 20% of Canadian Chinese elders were depressed in their study. I don't know, his criteria are looser than sort of diagnostic criteria. In the States, 18% of Chinese elders have depressive symptoms. That's Mui's work from the mid-90s. Japanese and Chinese American elders have the highest suicide rate among ethnic U.S. elders. Vascular dementia is prevalent. You know what vascular dementia is? Familiar with that? There's Alzheimer's disease, and then there's a bunch of other dementias. Vascular dementia is caused by an impairment of blood flow in the brain, and it's associated with the same risk factors as cardiac disease. But what is clear, and I think is true, is that these disorders are underdiagnosed and undertreated. And then finally, Chinese elders, as I said at the beginning, face significant barriers to diagnosis and intervention in mental health problems, and they tend to be detected at a later phase of their illness. Now, why is that important? It's important because if there is a tolerance of major problems, psychiatric problems, then the families tend to look after things internally for a very long time. They start to seek help when there is a crisis. That happens because of unavailable resources, not knowing quite where to go. Dealing with hospitals is a noxious experience for anybody, but especially if you don't speak the language. So there are a lot of barriers for people seeking help at an earlier stage. That was one of the things that triggered in our minds the thought that a better portal of entry, a more accessible portal of entry for this community might help with this problem. This is Daniel Lay's study from 2003. The data I presented in the last slide was 2000. So we looked at over 2,000 Chinese elders and just looked at their perceptions of illness, mental illness, and so on. Most agreed, interestingly, with Chinese health beliefs, so traditional beliefs, and we'll talk a bit about that. Their major concerns were the decline in their capacities related to aging, and these ran across the gamut of physical issues. They tended to attribute this to lifestyle problems with physical problems, and they were worried about their ability for self-care. There was a generally higher rate of physical ailments than the general population of elders. They showed poorer mental health than the general population. population, and they found these high levels of depression. The GDS is a depression rating scale which you can put the cutoff at different points if you want to. You can cut it off at 5, in which case you get a very high rate. You can cut it off at 8, in which case your rates of depression may be lower. So I'm not too happy with the GDS as a diagnostic instrument, but it's used frequently. So it's an indicator of depressive symptoms rather than depressive illness. The moderate to severe levels are 7 and above on the GDS, and he found about 6% showing those symptoms. So it's significant, and it's actually somewhat higher than the general population. Okay. Now, I thought it's worth coming back to this issue of migration, because when we talk about cultural groups, the tendency is to look at the group as though it is the cultural factors which are predominant in mental health story. I think that it's far more complicated than that, and probably the immigration story is a major factor in the differences in the mental health patterns in cultural groups. So I think it's more accurate to say that immigrants are at higher risk of mental health disorders. Elders in the Chinese community tend to have been relatively recently arrived. Some have come earlier and graduated into old age, but a lot of people have come brought over by their families. So they're at quadruple risk. They're old, they're an ethno-cultural group, they've got a mental disorder, and they are immigrants. Right? All of those factors. So why do I say that immigration is key? Because across all of these groups, it looks like elders who are immigrants are at particularly high risk of mental disturbance. Southeast Asian immigrants, especially refugee elders, and there are a number of studies that show that, older Korean Americans, Mexican Americans, Vietnamese male immigrants, especially elders. It's true that there's been Australian studies. So to be old and to be an immigrant is a risk factor. Belonging to a particular cultural group might be a risk factor, but I suspect it gets submerged under the other, under the immigration issues. So that's kind of the background, just to orient us to ethno-cultural or whatever. What time do we start?
We have an hour.
We have an hour. Till 10 after 1, does that mean? Or till 1?
1:30.
Oh, 1:30. Okay. So about 9 years ago, we set out to address some of these issues. We thought that the early identification of problems would be much more advantageous than waiting until crisis arises, which is the usual pattern. So if you look at emergency departments or at access points to the system, elders who come in are usually in crisis when it comes to mental health problems, and those crises often are psychosis, that is, loss of touch with reality, hallucinations, and delusions. Other kinds of problems tend not to come, and if people can hang on, they will hang on. Dementia, cognitive impairment, tends not to come for a variety of reasons, but that's another story. So we thought, let's take with the evidence we have, design a center that is based on that evidence, and see if it makes a difference. So this center was designed to meet the needs of ethno-cultural communities, but really the Chinese community to start with. And the goal was to have an efficient and timely access point for mental health care. It became clear in about 2004 that the geriatric population was the population that really needed this service, that we might be duplicating another program that existed in Hong Fu, which is a mental health center for the Chinese elders. I'm not too worried about duplication. There's hardly enough service to go around. But at any rate, we decided to narrow to a geriatric focus on the basis of the community's request. So in 2005 we did that, and the data I'll show you is all from that time period, the last 5 years. This was a partnership as well. So we partnered with Hong Fook Mental Health Association and Yi Hong Center for Geriatric Care. We did that for tactical reasons as well as practical reasons. Tactically, when a general hospital comes into a community, Sinai has a fantastic reputation. People think it's the greatest hospital around. I don't know what you think. But it's a pretty good place. And in the Chinese community, it's got a very good reputation. But it is clearly Western, mainstream, and the community often feels that it's a dominant organization coming in and just taking over and so on. We didn't want that. The last thing we wanted was that kind of perception. So we felt that it was important for us to have credibility in the community by, first of all, aligning ourselves with organizations that already have connections and credibility, and in a sense that we could be vouched for in coming in to do this. So there were many reasons for partnership. That was one of them. This was the philosophy. We began by saying that health is on a continuum from optimum health to chronically and severely ill impairment. And that illness moves along this continuum in some fashion for all of us. Either we jump very quickly from optimum health to severe illness, or we gradually move in that direction. Wellness, as we've called it, moves in the other direction. We call this center a wellness center, by the way, for mental health. Somewhere along the line, between wellness and illness, there is what we conceptualize as a tipping point. That is the point at which individuals move from a state of wellness to a state of illness. And there is a reason for conceptualizing it that way. But our philosophy was that if we're going to work with a community that highly values the concept of wellness, of self-care, of the promotion of health through diet and exercise and various remedies that are traditional in the environment, then we first of all had to recognize that, and secondly, that if we were going to intervene, we wanted to intervene around this tipping point where we move from being at an at-risk subsyndromal state. People who are not feeling great, managing, able to maintain themselves, but things are starting to happen. Demoralization, stress, pressure, so on. And who then gradually come to this tipping point. At the tipping point, they are no longer able. I mean, what's the point of this tipping? The tipping is that wellness interventions tend to be less effective at the point at which you move into the need to actually intervene with illness. So our program is an illness intervention program that is along a wellness continuum. That is, our goal is to be just past the tipping point, so we are getting people at the point at which they can no longer deal with their health using the mechanisms that they have used through their life to this point. In doing that, we consciously incorporate the knowledge that people in this program are actively seeking ways to look after themselves, and they are highly invested, as that lay study showed in 2003, they're highly invested in their own well-being and their own wellness. And they've got their own views of why they have come past this tipping point. So we set out to separate ourselves from a diagnostic, categorical, illness-based model, and adopted a continuum model that that embraced the ideas and beliefs of the people we're dealing with, rather than trying to force them into a Procrustean idea of how one should deal with illness. Okay. So our program has attempted to deal with the barriers to access to care in a systematic way. And the danger in doing this is that you can do a revision of history by doing a retrospective analysis. But we actually sat down, I can tell you, at the beginning and said, what are the barriers and how should this thing be designed in order to deal with these specific things? So we set out to deal with stigma and shame, first of all, and psychiatric illness. I just want to see if I made any notes on that I want to add here. So how do you do that? Well, first of all, dealing with stigma is a very, I don't know whether you're going to have sessions on this. Dealing with stigma is a very complex issue. There are lots of programs that have been attempted in dealing with this. The key, I think, to dealing with stigma is, first of all, to have some kind of conception of what to do, and then to do it for a very long time. That short-term intervention programs are interesting, but they actually don't make a change in people's perception. Things that really seem to make a difference in stigma prevention is, first of all, information and knowledge, and the media is a very effective way of doing that. But it's got to be ongoing. And secondly, contact. The data has, research has shown that that contact with people who have the problems that you're not that you are stigmatizing, let us say dementia or psychotic illness. Contact with such people reduces stigma and makes the awareness and understanding of the individual much clearer. And there's been lots of research in many different areas to show that direct contact, not just around stigma, but direct contact with others, with other populations, reduces this sense of self and other, this feeling that the other is so odd, strange. And once somebody is characterized as odd and strange, they are inevitably devalued by the larger group, as far as I can tell. So we did a number of things. We first of all decided to try to set up a program that didn't label people de facto by forcing them to come into a stigmatizing environment. That is a mental health program, a psychiatric program in a hospital setting. And we put the center into the community. So it is a satellite program. It sits, I'll show you where. And we named the center a wellness center, and we set it up as a non-institutionalized environment. We also put into place an active, ongoing mental health education program, both in the media and through other ways. We estimate that we're reaching about 2,500 people in the community annually. So it's we're kind of counting people who come to our booth at information fairs, counting people who come to our public lectures, and people who come to our education sessions. But the manager of our program is out, you can imagine, all the time doing this kind of stuff. So that's part of the program. This is the waiting room, the office. The signage is obviously culturally appropriate. The Wellness Center as a name generated some interesting reaction in the community. Mostly, it is very well accepted. We did receive a couple of letters at the beginning. I can't remember the Chinese term, but it was essentially you are a wolf in sheep's clothing. Right? You're pretending to be something that you're not. Really what you are is a psychiatric center, and you're just disguising it. So we thought about that, and because if that's true, then we're not only being dishonest, but we're going to discredit everything we're doing. I think in the end, it's not true in the way it's put. We are a mental health program, and we do provide treatment when it's necessary. But we are not a psychiatric program in the sense of a psychiatric program that you would find virtually anywhere else. It's quite different. I'll show you why. So what else creates a barrier? Well, we've done other kinds of work where we found that both professionals and patients, I can use that term, and their families just don't know about the illnesses, and they don't know what to do when something happens. We did focus groups with family physicians, and when we asked them, we gave them scenarios, diagnostic scenarios. So what do you think this is? And what do you think you would do about it? Essentially, what do you think you would do about it if you saw something like this? And it was quite interesting. If I was being dramatic, I would say astounding, that the degree of recognition amongst the physicians was modest. The knowledge of where to go and what to do with these problems was very low. These are people who worked. They worked in the Chinese community. They were very reputable physicians, certainly not stupid. And despite the fact that there was actually quite an array of resources around town, they didn't know. So if professionals don't know, then where are our families going to go? So this may seem like an obvious thing, but advertising and getting the word out about programs is essential, and it's not easy to do. It takes time. It's actually a bit expensive. You can do public service announcements, but sometimes you've got to print brochures, you've got to get out there, and you've got to really let people know what's going on. We put this into a storefront in a mall, and we set this entrance up as an information center as well as an access point. So we provide lots of information to people who just drop in as they're walking by, not just seniors, anybody. So we open this up to young and old alike, doesn't matter who comes in the door. We're focused on seniors, but we want to get the word to anybody who wants information. And we've got this community information education network that is going on aggressively. We have programs in the center for people who come in, and the topics are widely divergent. So we've had sessions on tea. The healing power of tea, because all of our staff are bicultural, bilingual, and some of them are quite expert in some of the traditional methods. And we just talk. When we did that at the beginning, we got, I think, other people who sent an anonymous letter to us, and they said, "You are putting us back into the dark ages of Chinese medicine by lecturing in this. You are espousing ideas that are witchcraft and voodoo," and they didn't use those words, but essentially that's what they were saying. "And we don't want to have anything to do with this. Western scientific medicine is what we should be doing, and we should not be talking about this stuff." So I'll just tell you why we're talking about it. I don't know about the healing power of tea, but I know about the healing power of belief, and I know about the healing power of establishing an alliance with people who are not certain what to do and where to go for help. And I know about the healing power of establishing a bridge. So the more one can embrace the understanding and the beliefs of others, the better that bridge is going to be, and that is the crux and the essence of effective medicine altogether, and certainly the crux of effective mental health care. So, but you've got to listen to that, because there is an evolving and shifting view certainly in the Chinese community, as I understand it, to a tendency to want to come to Western medicine, both here and back home in China. But embedded in that are other ideas and other beliefs But the other beliefs are back at that wellness end. They tend to be at the wellness end of things. So it is, we found that our Chinese patients don't cling to that and say, there's nothing else that will help me. What they say is that we need that, we want that, we think that's going to help us, but we know maybe there's something else that's necessary. So we wanted to set our programs up so that they engaged both ends of the spectrum at the same time. What are some of the other barriers to deal with? The families, as I mentioned, attempt to contain problems. It's well known in not just Chinese, but in many communities. There's also a reliance on the family for service utilization. That is, the elders can't easily go themselves to services. So geographically, if they're far away, they're not going to be accessible. And in part because the family has to take them. So family has to recognize the problem and be prepared to take time off work. And if they've just come to this country and are struggling, that's not an easy matter in itself. Finally, the family tends to misinterpret the symptoms or being unaware of them. This is just getting old. This is not a disease. Depression, what can you expect? People get depressed when they're old. Look at my mother is sick. She's got heart problems and arthritis. Who wouldn't be depressed? You think that too, but that's an attitude that doesn't lead to thinking about what the answer might be to a problem, but rather to an acceptance and a containment until it gets out of control, until the depression becomes suicidal or psychotic or whatever. So the program strategies are, first of all, culturally acceptable. There's more to say. The family as a unit of care model becomes essential. It's often the case in geriatrics as a whole, but particularly in ethnocultural communities where the family unit is more, I don't know if cohesive is the right word, but in societies that have a view of the individual as, in a sense, being secondary to the group, then it is the group that becomes the primary issue rather than the individual. And if that is then translated down at the family level, if the family group has a stake in what goes on, not just because they care about their mother, their father, their aunt, their uncle, but because the group itself is affected, and it is often a group decision that starts to be activated. And the decision-making sometimes goes from the top down. So it's hierarchical. So whoever has the power in the family can say, we're not taking her to the doctor, it's not necessary. So the father, for example, may say that, or I don't know who. So that family dynamic may be culturally affected and dominated by ideas that don't lead to action. Some of these things are a bit subtle about how the members of the education program then become ambassadors for the program in the community. We hope that. We've seen evidence of it. We don't know for sure, but we've never studied it. We did something else. Because we're concerned about early intervention, this is a study that we've just completed. It's not written up and published yet. It's just hot off the press, but we wanted to look at whether it's acceptable to Chinese elders to, first of all, to be screened for anything to do with mental health. And secondly, is there a method of doing that will enable earlier approaches to healthcare rather than waiting and waiting and waiting? Now, I tell you just at the outset that I don't know if it is effective to intervene earlier with these people around the problems that we've identified. I suspect it is for a whole variety of reasons, but I don't know. So I'm putting that aside. All I'm going to tell you about is what happened. So we studied, there are 7 congregate dining groups of Chinese elders across the city. They are for people who are frail and socially engaged and have difficulty with social engagement, but are able to remain intact enough to stay in their homes. they come to these groups for support. We looked at the geriatric depression scale and something called the Mini-Cog at the beginning, and then we reevaluated them at 4 months. When we did the first evaluation, we presented the findings of that evaluation to them on a written report card. We give it to them and to their families. And we said, we found that there's evidence of some depression or some cognitive change. We really recommend that you look for some help. Here's where you can go and what you can do. That's all we did. At the second 4 months, with the same group, instead of giving them the written report card, we sat down with them for half an hour, face to face, and we really talked to them, to their families, and we explained what was going on, and we made a link for them to the services. And we compared the help-seeking patterns that they engaged in at time 1 and time 2. Is that clear?
Yeah.
Okay. So we had almost 100 people, which is a pretty substantial number. Most of the people in these groups were prepared to engage. And there were quite high rates in our screening of both dementia and depression. Quite high, comparatively. Not as high as the annual A study of 20%, but still much higher than you would expect. 78 of these 96 completed the second round, and we had similar rates of disturbance. After we saw them in the face-to-face intervention, 76% of them committed themselves to seek further mental health intervention. We're finding out how many actually followed up. After the first round, where we just gave them a card, only 7%, 3 people, committed themselves to going for help. So I don't claim this is a definitive study of any sort, right? It's a little rough, and the methodology is something to be desired. But having said that, it's pretty clear that if you're going to help people access care, then simply telling them there's something wrong and telling them to go somewhere is not a very effective method unless you create some kind of relationship or bridge at the point of contact. We found that in many other situations. For example, the Alzheimer's Society is there for people with dementia in the community. Doctors may say, here's the phone number, you should call the Alzheimer's Society. The link, the uptake amongst people is actually quite low in those groups. So direct contact is important. The other thing we found was that this is highly acceptable to these seniors to be screened for depression and dementia. We didn't recruit them ourselves. We asked the people who are the leaders of the group to introduce us, and then to the group we had volunteers who then spoke to them. We had a little army of 45 volunteers doing this study, and people were, contrary to sort of mythology about stigma and I don't have anything to do with this, they were quite happy to do this. So we took from this, first of all, that people are prepared to be screened, that there is some value in screening because there are high levels of impairment in frail elders who are in these environments. They're not recognized in the main. Nobody knew that these problems were there, and they are unlikely to seek any kind of care unless it is discussed and a bridge made. Language and cultural barriers, worrying about the dominance of drug therapy and medication side effect, and culturally based beliefs about the determinants of mental health are all barriers to accessing care. So this program has not just clinical philosophy, it's got a human resource philosophy, and that is that, I don't even know if it's legal. I don't think it's legal in the States, but we will only hire from the ethnocultural community that we're serving. We've done that in our other programs as well, because we've got other things from non-geriatric programs. So all of our staff are knowledgeable about the Chinese culture. They all speak one of the languages, predominantly Cantonese. We've got one Mandarin-speaking clinician, and we've got a multidisciplinary team that can address, so that it's made up of social workers. It's not a big team, there's only 5 people, plus a psychiatrist, plus a kind of an information intake person at the front door. So we've got 2 psychiatrists, 2 social workers, what we're calling a psychotherapist, a nurse, geriatric nurse, and a part-time psychiatrist who is Chinese by background. So all of our programs present culturally relevant treatment options, and the goal is to ensure that patients who come in, people who come into this program, are not forced to choose to either go to a traditional program or to go to a mainstream Western psychiatric program, that they can do both things at the same time, and that we're going to embrace the whole package. So we don't tell them, if you want to, if you're interested in wellness strategies, go somewhere else. We involve them in wellness programs in this environment. What are these conceptions of mental health that are important? I don't know how much you've done here in this whole area, talked about it, but there's a lot to say. I don't want to give the impression that it's easy to categorize this stuff, or that by making broad statements we are somehow really capturing all the belief systems of the Chinese community. It's not like that at all. But there is a tendency. There's a tendency for there to be a lack of mind-body differentiation, so a tendency to see illness as being physical rather than emotional. And there's not a good language for a lot of emotional elements or descriptions. So the language of illness is often the language of the body. You have to interpret what's being said, because it means the same thing. My heart, I have, references to the heart. Somebody who's depressed are not so unusual. We've got our own phrases of heavy heart and so on. There are things like that. But if you just take it at face value, if a patient comes into a very quick family doc's visit and they say, I'm tired all the time, I just can't get moving, I think I'm not sleeping well enough, and I'm not eating well enough, doctor, and I think that's my problem. Can you give me something to stimulate my appetite? It'll be there is sometimes a tendency to just kind of, because the family docs have 7 minutes per patient, that's the average. So you got to move fast, and you kind of go for the first thing that seems to be relevant. But to do this, you got to dig deeper, and so there tends to be a somatic organ-based language. You got to get past that, and there is a tendency to want a holistic approach to mental health. A lot of physicians don't like holistic because it smacks of smacks of something that they don't like.
Lack of evidence.
Sorry?
Lack of evidence.
Lack of evidence, lack of sort of fuzzy-edged stuff, chicken soup stuff. Psychiatrists, on the other hand, they really allow themselves to think about what they do, know that chicken soup can be very helpful if you use it properly. So I don't want to get too chicken soupy here, but a holistic approach, if you're going to form an alliance, a therapeutic alliance with people, you just have to work from within their frame. As you work in that frame, they eventually start to trust the process, and then they will listen to your frame as well, or a combined frame. So we will develop our programs based on the intake. So we do a comprehensive intake of all clients, looking at the fullness of their life, their families, their cultural beliefs, their beliefs about anything that's wrong with them, their preferences in terms of wellness and self-care, and of course the full mental health-based diagnostic workup as necessary. Some people don't need any treatment, some are referred elsewhere. Those that come through, the majority, can enter one of three streams. Some people they just come in and they say, look, I know antidepressants are helpful, or this medication, or psychotherapy. They're quite engaged with the Western ideas. And they can generally go into what we're calling evidence-based care. It's not a very good term, but that's what they say for the moment. But it's really Western style. Some people have no use for this, and they're not ready. They just are not prepared to engage. So we then will involve them in what we're calling perception belief-based programs. Those programs are based on a whole variety of wellness activities, exercise and diet, and various kinds of education about lifestyle and pain management and myo-release programs and qigong and other things. I'll try to explain all of that. I'm not an expert in those things. People sometimes want acupuncture, or sometimes they want massage, sometimes they want herbal remedies, and we have partnerships with people who do that kind of work, and we actively collaborate around those programs. Do I think that those are effective for severe psychiatric disturbance? I don't think in the main that they are. Are they effective in creating an environment that is therapeutic? They are very effective in doing that. So where we're trying to move people is here, into these combined programs where they're doing both. And the majority of people end up there. So here's a pain management and relaxation workshop. Anybody can come to these things from the community. You don't have to be an identified psychiatric patient. So it's part of the destigmatization of the process. So we open these things and we don't identify who's a patient and who's not. There's no need to. Everybody knows who they are. And people who come often come as a first step to do this, and then they start to ask questions. My mother's having trouble. What can I do? Can I help? And so on. This is a traditional exercise class. This is public lecture again. Chinese health practices. Okay. So I don't want to beat this to death. What other factors are important? The services have to be geographically accessible. Elders can't travel very well. They won't travel often. And again, the family issue of having to get to things. So if we're going to have effective programs, they've got to be in the community. That's why we put the community in Scarborough. We had a big debate. Should it go downtown into this population or up in Scarborough? We asked the community. We talked to people in the community. Everybody said, put it up there. I'm not sure whether we're really meeting people in the greatest need or not, but we're meeting a large population, and that's where the Chinese population is. The problem is it keeps moving a little bit, and we can't move as fast as they do. So we're in a storefront location in a shopping plaza. It's a Chinese plaza. All the businesses there are Chinese. They weren't too happy with the mental health service coming in there. They didn't know what it was. Psychiatry, mental health, Sinai, what's this going to mean? We started buying their services at the beginning. We bought our blinds from the blind guy. You can see. we bought our food from the bakery. We go to the restaurants. We engage them. The pharmacist came in. We started talking to them, and this thing's been thoroughly embraced. there and in the community. But there are strategies for community engagement that are really important in opening any kind of portal in an ethnocultural community. This is where we are. We're way up on middle of McNichol in Toronto. Most people have no idea where that is. This is the storefront. It's just on the corridor of the mall. So, under detection, how do we deal with long waiting lists and the delay in health seeking until a crisis arises? I'm not going to go into all the details, but we've simplified our referral process. Anybody can walk in the front door. If they have a referral, that's great, from a physician. About 27% of our referrals come from family physicians, but the majority do not. About, the stat comes up later, but about 45% of patients are self-referred. That's very important to us, that data, because it means that people are using this in the way that we hoped, which is a portal of access to care. And we see them right away, relatively. So our waiting period...
Oh, sorry, I didn't mean to interrupt, but I just wanted to ask, when you say self-referred, could it be that they come in off the street to do an exercise program or to attend a lecture, and then that's when they start asking questions and end up seeking further treatment? That's
one way. Another way is they just walk in the front door. Another is they've heard about it on the radio or whatever, and they phone up. Families will phone. The elders themselves will come in, or friends. So this is actually a major issue in the healthcare system, because if you want to go to a specialty service, in the main, you have to get a referral from your family doctor. Now, if your family doctor doesn't know where to send you, that's a problem. If your family doctor doesn't identify that there is enough of a problem to go, they won't make the referral. If you're afraid to tell your family doctor that there's a problem, or if the nature of the examination is such that there's just not enough time to get it out, or if you're ashamed or feel stigmatized, that access point doesn't always lead effectively to care. So what do people do? They go to social service agencies in the main, elders in the Chinese community and the Tamil community, I know for sure because we did the study, but elsewhere as well. They go to places they trust and know, where people speak the language, where they've heard about the program and so on, and they ask for help. Those programs are not funded and not trained to identify mental health problems in the main. Not only that, but their mandate sometimes specifically excludes mental health problems. So there's a dead end in many sort of social support agencies in the community, and community centers and stuff, churches. So anyway, so we simplified the referral process to open it up. I talked about this at a retreat yesterday at the Department of Psychiatry at Mount Sinai Hospital, and people were quite interested in the idea of actually having open access programs. It's tricky. It's medical legally tricky, and it's tricky for other reasons. As a consultant, if somebody is sent to me and I see them once, if there is no referral that's been made, then I become the frontline practitioner. And if I'm the frontline practitioner, I can no longer say to the patient, got a problem, here's what you should do, goodbye. So if you have a family member and you go to a geriatrician, a medical geriatrician, they all work on assessment and consultation. They very rarely do treatment. So they're not frontline practitioners. That's a problem to be a specialist on the one hand and to be in the front line on the other is an issue. So you have to really be prepared to take things on and continue with them and manage them if you're going to open a portal of access. The referral process works for a lot of stuff, doesn't work very well for this kind of stuff. Okay, we're focused on early intervention. And this slide is kind of just a client comes into the wellness center. We have a relationship to nursing homes and community services as necessary. We deal with the families as necessary. We have a direct, this is important actually. Community services that are attached to a mainstream service can set up a continuum of care. One of the things that breaks down in elder ethnocultural care, probably any elder care in the community, is the absence of a continuum. So you can do things in the community, but it doesn't get into the higher levels of intensity of care that can be offered in a hospital until and unless you either form a partnership or you've got it right there. So in our program, we're community-based, but when necessary, the patients can come down to a specialized, sort of ultra-specialized geriatric psychiatry team that Sinai will do. Imaging, will do psychological studies, will do whatever is necessary. We'll collaborate with our community team to do that, and then we get our reports back to the places they need to go, so that the nursing home that's having trouble, or the family doc, or somebody else who's turning upside down here, I don't know who that is, the service agencies end up getting this high-level information and knowledge about what's going on, recommendations for treatment, and then we'll work with them in a treatment capacity. So the program evolved slowly, just to tell you, not because of this program, but if you start anything, you've got to be prepared for gearing up. So we've had over 300 cases, 130 of them in the last year. So things really start to ramp up very, very quickly as it starts to take hold. It's like a new garden, you plant stuff and it's all like this high for 3 years, and then all of a sudden you've got jungle in your yard. If you've ever done that, I just did it, so I know. So that's what happens. We're hitting the population that we want, so when you put it in the community, you'll get the population. So 98% Chinese as their first language. 70% speak little or no English. So this is a disadvantaged population that's unlikely to go anywhere else. Most of them have no history of psychiatric care in Canada, so we're getting new cases, new people who have not been identified before. Almost half are self-referred, and the referral patterns have gone straight up. And this last statistic is important. The duration of care for ethnocultural populations is often very short in mainstream services because people don't stay. They don't stay for a whole bunch of reasons. Probably the matching, the language, it's probably complicated, and it's true for all ages. It's certainly true for the elderly. So the fact that 85% of this clientele stays for more than a year in this program at varying levels of intensity is a very high retention rate. We're just looking at comparisons now with other studies to see where it actually sits. But so what it means is that it is effective in not only assessing people, but also in engaging them in the treatment process. That's a major issue for any mainstream institution. I say this not to brag about a program, but I think to really think about principles of care, principles of a system that has this responsibility for addressing the intersection of all of these factors: age, culture, language, migration status, mental health issues. I'm not going to go into this, but most of the people we're getting are depression and anxiety. Everybody loves the program. I'm not too happy about satisfaction scale, I don't know if you just did a survey in the community, whether you ask people if they're satisfied with the services they're getting in general, whether they would all say, yeah, it's okay, or whether we would see higher levels here. So we've got no comparisons. So it's great, but grain of salt. But what they do value are the language appropriateness, the ethnic staff, the environment, the respect of culture, and the location. It's kind of the top 5 things that they cite as being most satisfied with. And this is all the data for those things. We don't have to go through each of these charts. If you're going to ever set up a program, be prepared for skepticism. It's easier if you come from the community. Not from the community, then you got to find an interface. There's power dynamics and partnerships. Hospitals are not trusted in community services very well. It's not they're not trusted, it's the wrong word. They're resented because they get all the resources perceived. So UHN has, I don't know what, $1.5 billion. They've got like 10% of the Ontario healthcare dollars in one place. I'm speaking out of turn because I don't really know for sure, but a lot. So, what's an agency funded for $150,000 a year going to feel when they're struggling to deal with all of these problems? They don't have money, they don't have staff, they don't have resources, and they see the hospitals getting everything, and then the hospital comes in and says, we're going to do what you're doing. They don't like it. So it has to be negotiated and worked out and really sensitively thought about, and a lot of collaboration developed. It's challenging to balance medical and non-medical activities. It's not highly acceptable in the system. More so now than it used to be, but slowly evolving. And medical care in itself is very time-consuming if you do it right. It's challenging. You need a lot of expertise, and you can't do everything for everybody all the time. So to put it all together really takes an effort of will and a model that works. It's not easy to integrate with the mainstream operations. When I was chief at Sinai of psychiatry, these programs started, and I made a lot of effort to integrate these programs into the life of the hospital. There are a lot of people attached to these programs, our ethnocultural programs. It's probably the largest sort of entity, if you wanted to call it a coherent entity, of any of the programs in our department. But I don't think we've overcome the challenges of staff that, first of all, work in the community and are, I think, viewed as other by the people who work in the department. It's not malicious. It is not in any way overtly prejudicial toward one group or another. It's not like that. This is the most, I would say, wonderful group of people you could ever imagine working with in a hospital setting and anywhere else. But there is this problem of the integration of services into the mainstream. They don't naturally fit in. And finally, we're always challenged with resources. So this program, to tell you, is funded by the Ministry of Health through its community mental health program originally, and they funded it on the basis of the evidence and the research that we did and the need of the community and a little bit of political maneuvering and some other things, I guess, that the hospital support. But the development of any program of this type, and I would say this is kind of a model demonstration project, it's substantial, but if it's going to be expanded, then it'll have to be expanded on the basis of demonstrated effectiveness. And so everything that we do in this area needs to be demonstrable, evidence-based as much as possible, and embraced by both community, hospital, and government. So, thanks. I'll stop there.
Does anyone have any questions for Dr. Sadavoy?
I have a question towards the barriers and facilitators you were talking about. You pointed out a lot of the barriers that are also parallel actually to the area I work in palliative care. I was just interested in seeing whether you think that there's some of the facilitators towards services for mental health that you see either coming out of the community itself or from sides of the mainstream medical community or the ministry, like the demonstration project you were talking about.
You're asking about facilitators in other sectors and other places. There are some. So the organization that started in the Chinese community, the Hong Fook Mental Health Association. Is that what you're asking about? Those kinds of things. Hong Fook has been a growing organization, and they went from being a community-specific to a much more embracing ethnocultural program. And in the last 5 years, I'd say, they've been increasingly providing actual mental health care in their program. So they started out as a case management service, and now they've actually got psychiatrists who come in and are providing care to members of generally the Chinese community, but also the Korean community, and I think they've got a Vietnamese psychiatrist as well. So they're broadening their scope and looking at becoming an ethnocultural rather than a culture-specific organization. Yihong Center for Geriatric Care has 5 sites, I think 5 sites now in Toronto, all over. They've got one in Mississauga, they've got it in the eastern side of Toronto, they've got 3 in kind of the Chinese community area. It's a very, very effective organization. They've got 1,000 beds, I think, scattered. And they've begun to, working with us actually, begun to look at the issue of mental health. They had not thought about this before. And they're starting to look at things like the support of family caregivers, highly vulnerable population, people who are in the community looking after people with dementia. So we've got a program that we've started in that area. They've embraced that, and they're looking at doing that. They don't yet have a real mental health consultation program within their center. It's available, but I don't think it's widely used. So they're still at a sort of pre-adoption phase of this. Other programs pay some attention to culture. Scarborough General Hospital, for example. But when it comes to actually dealing with hardcore stuff in the community, difficult problems, they come to us and they say, we really can't do it, or the families come, the patients come and say, we're not getting what we need for one reason or another, and so on. So I think there's a movement in this direction. It's slow. What I've observed in government policy is an immediate embracing of the need to consider culture in everything we do. When you look around the table at the policy groups, at people who are doing this work, you don't see the reflection, and it. Whenever I raise this, I always feel as though I'm raising this as waving a flag. I would love to see the flag just kind of lying on the table that everybody looks at all the time. It's still not a natural process. It is recognized, however, in the system. It's just not part of the natural thinking and the development of things.
Thank you for your interesting presentation. I want to know, in the future, whether the wellness center will expand its care from focusing only the Chinese community to all the Southeast Asian community. I think that because certain populations, minority, might need also same service, but I mean that because their community may be lack of opportunity or leadership.
So it needs a champion. To do this needs a champion. The Chinese community had some sort of championing in its midst for the development of things. And there was a particular moment in time when it was useful, probably, and appropriate for the government to fund something like this. And we had evidence, and we had, momentum, and so on. To simply go back now and say, this is a good model, it should be in the other communities, we're going to have trouble, because at the moment, the answer that we're getting is, there's no money for health care. We don't have the funding, so the old story. And so the question then becomes, what's going to get priority? There's money, billions of dollars, but what's going to get priority? How's it going to be distributed? So if this is going to expand to other communities, I think a lot of it is going to happen because of, for political reasons, not reasons of need. Everybody knows the need. Having said all of that, there's an application in now before the government to expand the wellness model to other communities. So if that happens, I'll be happy to come back and talk about it. We'll see. These are expensive things to do, but not as expensive as an MRI machine.
You mentioned that there were, I thought it was interesting when you said that a lot of people go to social services instead of going to their doctors for whatever reasons. And I'm wondering, how do you address, like, if you can expand on how you address the barriers? Because you said that a lot of social services mandates don't like accommodate what your program is doing.
It's a very, very good question. From a sort of structural and process point of view, we've put a lot of effort into connecting with the various social agencies in the community and talking to them about what they encounter and what they see. We have offered, and some have taken us up on, having staff meetings with them to talk about clinical problems, what we call clinical problems, what they call problems that they're not sure what to do with, and so we actually go into the agencies and meet with them. We've also opened ourselves to being called should problems arise, and they think that maybe we can be helpful. We've got an education program for frontline workers in the community. Most of the people who come are from Yihong. They're social workers, but there are some other agencies that come. Students will come. So for about 6 months of the year, we run a seminar program in geriatric mental health for these workers to try to bring them to a level of understanding that enables them to at least appreciate a little bit of what they're seeing and where they might go for help. So education, direct consultation, so-called primary consultation. So we'll actually see the people that they're having difficulty with and then talk to them about it. Secondary consultation, that's consultation to the staff, going into the environments themselves, and then opening a channel of communication. So kind of what is called in other areas shared care. It's a model of shared care with family doctors that has been used in Hamilton and in Toronto and elsewhere. We do it here, where family physicians can, if they see some problem, we see them in consultation, send them back to the family doc, and then we'll be there at the end of the email or phone line for discussion and ongoing consultation around care. We'll do the same thing with agencies. It's the best we can do. We don't have enough staff to do that in a broad enough fashion.
One more question. I'm not sure if I understood these statistics correctly, but you mentioned that the average care that people receive or come for is 14 days or less?
No, the average waiting period.
Oh, waiting period, okay. But another question might be, does the fact, like, immigration status influence people who come in, like how long they can stay? Because I think, I don't know if this is correct, but certain people who come to Canada, when we have a certain amount of visits, they can have a psychiatrist
Yeah.
for a year.
Actually not.
Okay.
It depends. If somebody's on an insurance plan, funded somewhere else, then they may limit the number of visits. But if they're on OHIP, there's no limit. So I think people get on OHIP fairly quickly after coming here once they're here as kind of semi-permanent status. Certainly after they landed, of course, that takes a long time. But after they get immigrant status and they're here, so they can get OHIP. There's no limit. Even if there were a limit, the majority of our program is globally funded. It's not fee-for-service, so we don't worry about insurance, and people don't have to pay anything for this program. When they see the psychiatrist gets paid by OHIP. If they don't have OHIP insurance, then the psychiatrist doesn't get paid. Occasionally we'll do that just because it's necessary. Can't do that for too long because it becomes a little problematic. But I don't think anybody goes untreated in this program because they're immigrant status.
Thank you.
Okay, our time's up.
Thank you so much. That was wonderful.
Most welcome.